Hi everyone, Dr. Dave Richardson. I am your instructor for today's webinar, which is entitled, What is MedDRA and How is it Used? Assisting me today is Sarah Clark, who is one of the training coordinators with the MSSO. I'd like to start out with some housekeeping details more than anything else. We are scheduled for a 2-hour session today. I can tell you with absolute certainty, I don't have the ability to ramble on for 2 hours. So more realistically, I think that we will be able to cover the material somewhere between 75 to 90 minutes time, and that will give us plenty of time for questions that you might want to pose to me. As Sarah has already mentioned to you, we have a chat box feature on this platform which allows you to type in questions. And I will stop periodically during the webinar and check with Sarah to see what questions have been posed and attempt to answer those. If there are any that I cannot handle or do not have the necessary information about, we'll hold on to that and we will forward it to our help desk, making sure that your issues are addressed. The other thing that was mentioned is log-on credentials for an application called PollEV. It's a polling tool. For this particular webinar, I am not going to use PollEV. So if you had any difficulty with accessing it or were not familiar with how to use it, don't worry about that, because this particular webinar tends to be less interactive. It's more of an informational webinar where I'll present some information about not only MedDRA, but also the MSSO. So let's also get on the same page in terms of what this particular webinar is supposed to do. This is a high-level overview of the MedDRA product for those who know something about it or know nothing about it but want to get a good idea of what MedDRA is capable of. We'll also say a little bit about the MSSO, which is the organization that I consult for, which is responsible for the maintenance of MedDRA as well. I will show you and demonstrate a few tools that are related to MedDRA, but this is not going to be in-depth on any of those particular topics, because one of the things that I'm going to state now and emphasize during the webinar is we present multiple ways and multiple platforms for educating yourself about MedDRA, including other webinars such as this on coding, data analysis. We also have face-to-face courses, video casts, and a number of other resources in terms of interactive courses that will allow you to improve your MedDRA knowledge as well as be able to use the tool more efficiently. But the intent of this webinar is to give you an overview of the product with the presumption that you are relatively new to MedDRA or want to understand the full breadth of services that you can have using the MedDRA terminology. So with that long-winded introduction, why don't we move forward with today's webinar. So again, I'm Dr. David Richardson. I'm a physician by training and specifically an adult neurologist. I'm a medical officer with the MedDRA MSSO, and I am physically based on the East Coast of the United States in Annapolis, Maryland. This slide is to remind me to tell you that MedDRA is owned by ICH. And because it is a living and breathing terminology that requires maintenance, ICH created an organization called the MedDRA Maintenance and Support Services Organization, or MSSO. The MSSO is responsible for the ongoing maintenance of MedDRA. That includes educating people about the use of MedDRA, as well as adding, editing, and maintaining the platform itself. And the activity of the MSSO is overseen by an ICH MedDRA Management Committee, which is made up of ICH parties, MHRA, Health Canada, and the World Health Organization as an observer. Now, this is a busy slide that I will summarize as follows. The first bullet is to remind me to tell you that the material that I'm going to present is copyrighted material and that ICH owns the copyright. With the exception of the MedDRA and ICH logos, you can feel free to use this material in public presentations as long as you acknowledge that ICH owns the copyright. However, if you change the content of the presentation in any way, shape, or form, you should not imply or infer that ICH either supports or endorses any of the changes that you've made. The second bullet is legal language, and therefore I will read it verbatim. The presentation is provided as is without warranty of any kind. In no event shall the ICH or the authors of the original presentation be liable for any claim, damages, or other liability arising from the use of the presentation. And the third bullet refers to third-party slides, and since we don't have any in this particular webinar, I'm going to skip over that altogether. Okay, so what are we going to do today? I'm going to present some background information about MedDRA and the governance of MedDRA. We will look at MedDRA's scope, structure, and characteristics, how it's maintained. I'm going to describe some tools and actually demonstrate some MedDRA tools, specifically the MedDRA browser and the MedDRA version analysis tool, or MVAT as it's called. We will talk a little bit about coding with MedDRA, which is the way that most of you are going to use the terminology. I'll introduce you to a suite or group of documents called Points to Consider documents, which are ICH endorsed documents that are allowed to make you more efficient, more effective MedDRA users. I'll then describe another resource that we provide to you, so-called standardized MedDRA queries, or SMQs as we call them, and how you can use them to look at MedDRA coded data to understand perhaps some issues that your product may have that you may not be aware of with just casual inspection of your data. And then we're going to move forward to our question and answer section, and that's the basic outline of what I'm going to cover for you today. So let's talk about MedDRA's background and governance. So what does MedDRA stand for? It stands for the Medical Dictionary for Regulatory Activities. Now, a couple things I want to point out. Even though the word dictionary is in MedDRA, it is not truly a dictionary. It is a set of terms, and we'll see that when I open up the browser and show you. But this is not a dictionary in the sense that you will not find definitions of any of the MedDRA terms within MedDRA itself. So whenever you are using MedDRA, my recommendation is, because MedDRA is heavily skewed with medical concepts, that you have some access to a reference, a medical reference, whether it's a website, an encyclopedia, a medical text, whatever. And I would even make that same suggestion to colleagues who are physicians, who are physician assistants, nurses, etc., because MedDRA covers a whole scope of clinical concepts across multiple subspecialties. So even I, as a neurologist, very often will run across a cardiac or respiratory concept in MedDRA that I don't have familiarity with, because that's not the type of medicine that I practice. So it's a good idea to have a resource available for medical information when you're using MedDRA. And even though it says for regulatory activities, what we have found with time is, even though it is used in the biopharmaceutical development area or industry, a number of other people are beginning to use MedDRA as well, who do not necessarily develop drugs, vaccines, biologics, etc. And this can include pharmacists who are doing research from the perspective of a drug formulary, or social science researchers. And because we are actively involved in mapping initiatives of mapping MedDRA to other terminologies such as ICD or SNOMED CT, it may be that we have other folks involved who are not involved in actual drug development, but maybe more on the side of patient care delivery. So I wanted to just clarify those 2 points about the definition of MedDRA. So what is it? It is a clinically validated international medical terminology. So it's a medical terminology, as I said, with over 100,000 terms in it. It is an international terminology in that it is used around the globe. And we say clinically validated. And the clinical validation of MedDRA is quite interesting. We, in fact, produce a terminology that twice a year we update by adding additional terms to it. And the clinical validation of MedDRA comes from each time we put a new version of MedDRA out, which happens in March and September of each year. We hold our collective breaths at the MSSO and wait for those who are users, such as you, to get back to us and tell us where we're making mistakes, where things were put, when we put something in there and you don't agree with where it was put, or when you think there are additional terms that should be added. So that's where the clinical validation comes from. We make our best attempt to create a sound and solid terminology, but the proof of whether we are doing a good job is the feedback that we get from you as to what we've created and whether you think there is additional information that needs to be added to MedDRA. So, not only does the biopharmaceutical industry itself use MedDRA, but the regulators that regulate that activity use MedDRA. And it is used throughout the entire regulatory process from pre-marketing to post-marketing of products. Now, MedDRA can be used for several things, but the one that most people concentrate on is data entry, which is synonymous with the term coding, where you get a report. Doesn't matter whether you get the report from a patient, from a doctor, from a pharmacist, or even from an online source, but you decide that there's some concept in that report that you need to put in your database. And the way that you do that is to go into MedDRA and find the appropriate term that you wish to code, use as a code to capture that concept and put it into your database. And we'll talk about that in greater depth in a few slides. The other important thing is once you put MedDRA coded data into your database, at some point you're going to want to go in and retrieve it, evaluate it, analyze it, and maybe present it, maybe internally in an organizational meeting, or maybe at the end of a clinical development program in creating the application that you are submitting to get marketing authorization in some region of the world. This is just to emphasize that MedDRA is in fact an international and global terminology that is now currently used in over 130 countries. So what is the purpose of MedDRA? Well, in a nutshell, it allows us to exchange clinical information. When we look at MedDRA and look at the hierarchy of terms in MedDRA, you're going to see that the vast majority are related to clinical concepts, things that happen in organisms that are receiving drugs, drug products, vaccines, etc. But one of the things that is crucial about MedDRA is the terminology is standardized, so that even though MedDRA is released in multiple languages, the terms that are in MedDRA are standardized. And so if I am using the English version of MedDRA and you are looking at the Spanish version or you are looking at the French version, the terms that are in there are going to be standardized. And that is important in terms of the power of MedDRA, that it is a universal terminology where there is consistent terminology in all of the language versions that are released. It is an important tool for evaluating your product, whether your product is a drug, whether your product is a vaccine, whether it's a biologic, whether it's a device-drug combination. It's important for monitoring your product. And for most manufacturers, that would be in terms of clinical safety issues. It also allows you to communicate about your product, either internally or externally, for instance, with a regulatory agency. And that's why the standardization of the language within MedDRA is so important. And MedDRA is also, as a unique terminology or language, another way of exchanging information electronically. And then the last point here, oversight, really refers to the regulation or the regulatory aspect of those organizations which regulate the development of products use MedDRA to evaluate those products for both their safety and their efficacy. So MedDRA supports not only data entry and coding, but also, as I said, retrieval and analysis about clinical information obtained with human medicinal products. And that includes drugs, blood-derived biologics, vaccines, and drug-device combinations. So let's talk a little bit about the governance of MedDRA. So the ICH MedDRA Management Committee was appointed by the ICH Assembly to provide oversight of MedDRA-related activities. And this is what the MSSO is responsible for doing, for maintaining the terminology and making sure that it's current, that it is accurate, that it's useful, that it meets our client or user needs. So let's talk about this relationship. ICH owns MedDRA, and the ICH MedDRA Management Committee is responsible for contracting with the MSSO to maintain the terminology. They have oversight of all of the operations of the MSSO. They regularly meet with us. They set the subscription rates that you pay for an annual MedDRA subscription, and they approve any ideas in the MSSO for new development plans or services related to MedDRA. Now, this MedDRA Management Committee includes membership of not only ICH regulatory authorities, but also industry associations as well. So again, the MSSO is responsible for international support and development of the terminology. I say here that we are the custodians, not the owners of the terminology. And people often will laugh and say, sure, you own the terminology. No, we are truly custodians, because every 6 months when we add somewhere between 1,500 to 2,000 new terms to MedDRA, probably 98% of those new terms came because users like you communicated to us that you thought that these were terms that needed to be within MedDRA. We talked about the governance as being administered by the management committee, but I also mentioned that the MSSO is responsible for educational offerings, including webinars such as the one that I'm conducting for you today. And we also at the MSSO have a partnership with a companion organization called the JMO, or Japanese Maintenance Organization. And they are responsible for maintenance of the Japanese language version of MedDRA. So getting back to my earlier comment about the use of MedDRA throughout the entire biopharmaceutical product development process, this is a very, very helpful slide in answering the question, where exactly is MedDRA used? So first of all, I want to show you this rectangle. And this rectangle here relates to development of a product. So let's start with what's outside of that rectangle. Well, the first thing you'll see is preclinical testing. And preclinical testing are things that might be done with your product before it's ever introduced into a human being. So these are things that you would do in preclinical testing with mice or rats or guinea pigs, for instance. And MedDRA is not intended to be used for capturing any of the information that you derive in preclinical testing. However, once you begin an actual development plan, starting with phase 1, going through phase 4, MedDRA is in play and is used in a number of different ways in a number of different places. So in the classic drug development model, clinical phase 1 is when you take your drug and you give it to normal, healthy volunteers, looking at things such as how well is the drug tolerated, as well as trying to get some idea what the dose range might be for that particular drug. And then, if your drug passes muster in phase 1, you then begin with phase 2 and phase 3, where you are then effectively giving the drug to increasingly larger numbers of patients with the disease of interest. Now, this is typically done with providing the drug to patients as well as to, providing the drug to patients, some of whom receive the active drug, and in the classic role of drug development, some of them are receiving placebo. But the whole point here is you are taking actual patients with a disease of interest. And once you have enough information on the safety and efficacy of your drug, you present that data to a regulatory agency who will review that data. And if they give you marketing authorization for some region of the world, you now have a marketable product. But even then, you may continue to do studies with an approved product, and MedDRA still would be used in this phase 4 of drug development or enhancement. So here's a list of some of the kinds of places where you will see MedDRA used, not only in databases of companies and regulatory agencies, but in safety reports, safety summaries, and clinical study reports. When you are just beginning development of a drug with a new chemical entity, and you are going to get investigators to do trials for you, what you know about the drug is all put into something called an investigator brochure. And because it's a new chemical entity, it's possible that your investigator brochure is relatively short. It could be 25 pages long. But in fact, as you begin to introduce the drug to subjects and patients, you're going to start to get a lot more information, particularly from the point of view of tolerance and safety. And your investigator brochure gets larger and larger. And some of these medical concepts are going to be coded with MedDRA within the investigator brochure. It is also used in things like the core company safety information, in your actual marketing application seeking approval, publications about your product that you might put out in the medical literature. And in fact, if you get your drug approved, you need to have some prescribing information for healthcare practitioners, and MedDRA is used there. Now, the last one is interesting to people who live outside of the United States, where we have advertising. Because in fact, in the United States, when you are watching television at night, watching the news, we allow commercials on TV for prescription medications. And in those commercials, they will describe side effects, potential side effects of drugs. And those side effects are usually MedDRA codes that are being presented. So you see MedDRA even when you're watching television at night here in the United States. So this is just an overview of where MedDRA is used. Okay. Let's move on now and talk in a little bit more detail about MedDRA, the product itself. We're going to move away from the governance and the theoretical point of it and talk about what the terminology actually looks like and feels like. And we'll look at its scope, its structure, and its characteristics. So this is the scope of MedDRA. And this is an important slide that I'll spend a few minutes on, because in my experience, when someone complains that MedDRA is doing a bad job or they're unhappy with MedDRA, it's typically because they're asking MedDRA to do something that it was not designed to do. So we have this blue circle, and inside of the blue circle are those things that are within the scope of MedDRA. But I want to start by looking outside of the circle for those things that are outside of the scope. Because again, when you're disappointed with MedDRA, typically it's because you wanted it to do something it wasn't designed to do. So first of all, it's not a drug dictionary. If you want a drug dictionary, use Who Drug, for instance, a much better product designed for that. MedDRA is not going to have a lot in terms of patient demographic information. The only exceptions will be when a demographic characteristic adds valuable information. For instance, the difference between female breast cancer and male breast cancer, because there may be a difference in the pathophysiology, the actual pathology that is seen, risk factors, or maybe even the types of treatment or responses to treatment. You're not going to see much in the way of clinical trial study terms, because again, MedDRA is not only used by people who develop drugs, it's used in a number of healthcare settings, increasingly as we begin to map MedDRA to other kinds of terminologies. MedDRA is going to have a term for headache, but MedDRA is not going to have a term for 12 headaches. So in fact, if you care about the number of times that an event occurs, you need to come up with some other way in your data collection instrument to quantitatively capture the number of times or frequency of an event. MedDRA does not have numerical values for test results. And that's because the normal ranges for a lab can vary significantly from one lab to another, even within one city or within one neighborhood. The other point as well is that certain labs are measured by different scales in different parts of the world. So you can measure glucose as milligrams per deciliter, which is what we do in the United States, but in Europe it would be millimoles per liter. So therefore we don't capture numerical values. Instead, we tend to have qualitative descriptors in MedDRA like high, low, increased, decreased, normal, abnormal. Also, there's subjectivity involved in determining the severity of a disease. So MedDRA doesn't tend to have a lot of terms like mild, moderate, and severe, because if you get two healthcare practitioners together, you may not get agreement on whether a case of rheumatoid arthritis is mild, moderate, or severe. However, in fact, if you are interested in following the progression of a disease or disorder, specifically a neurodegenerative disorder or a cancer, there are clinically validated scales and classifications that allow you to do that. And you should lean on those for capturing progression, not MedDRA. It's not what it's designed to do. And more specifically, in the way that I said, it's not a drug dictionary, it's not an equipment, device, or diagnostic product dictionary. So that's what it's not. But let's talk about what you can use MedDRA for. You can use it to code medical conditions. And everyone seems to know that about MedDRA, that it's very good for coding signs and symptoms of diseases and disorders and side effects. That's great. But look at the other ways you can use it, and sometimes ways that are required in a particular region depending upon the regulatory environment. You may need to use MedDRA to code the indication for use of a product, to code investigations such as labs that you do, x-rays that you do, and the results of those investigations. You may need to use MedDRA to code procedures, both surgical and medical, various kinds of history, not only medical history, but social history and family history. Now, those are all related to the patient or subject. These other ones look more from the perspective of the product itself or the way in which the product is manufactured or administered. So this would include things like medication errors. Did somebody make a mistake and give you too much of the drug or give it to you the wrong way? What about product quality issues? What if you open up a bottle of pills and you find slivers of metal in the bottom? That is a product quality issue. It could very well turn into a patient issue if a patient mistakenly swallows some of those metal slivers and ends up with, let's say, damage to their intestine. But again, MedDRA allows you to capture product quality issues, device-related issues, product use issues. This one I love, which is pharmacogenetic terms. In the good old days of medicine, when I first practiced, there was a book in the United States called the Physician's Desk Reference. And you would open up that book to learn how to prescribe a new drug. And typically, the instructions would read something like, start the patient at 25 milligrams a day and increase by 25 milligrams every week until they either get all better or they get an intolerable side effect. Nowadays, we rely much more on the genetics of individuals and populations to not only select those that we want to give a drug to, but also decide how much of the drug we want to give. That may actually help us in deciding whether someone is even a candidate for the drug if their genetics suggest it's not going to be helpful for them or that they are more likely to develop a side effect. So this would be a situation where you might open up the prescribing information for a drug and it will say, the very first thing you need to do is determine whether they are a fast or slow CYP3A4 metabolizer. CYP3A4 is one of your liver enzymes that metabolizes drugs. So if you are someone who's a fast metabolizer, then the instructions may say start them at 100 milligrams. Whereas if they are a slow metabolizer, the instructions may say start them only on 25. So pharmacogenetic terms are becoming an increasingly large area of the MedDRA terminology as well. We also have toxicologic terms, and we also have these so-called standardized MedDRA queries that are built into MedDRA itself that you can use to query or look at coded data to try to reveal to you hidden problems, diagnoses, disorders, etc., that patients may be experiencing while taking your particular product. So MedDRA is a terminology, and it is a terminology that has 5 levels, and these are the 5 levels of MedDRA. The top level of terms in MedDRA is the level of the so-called system organ classes, or SOCs as we call them. There are 27 SOCs in MedDRA, and I'll show them to you on the next slide. But below each one of these SOCs, we have a second level of terms called the high-level grouping terms. And there are about 300 of those in the current version of MedDRA. And below these HLGTs are high-level terms, which we call HLTs, about 1,700 of them in the current version of MedDRA, which is 27.0. And then below that is a level called preferred terms. Now, these preferred terms are the level of medical concepts within MedDRA, and there are over 26,000 of them in the terminology. And then here at the very bottom are the lowest level terms, over 88,000 lowest level terms in version 27.0. And when you are coding with MedDRA, you want to firmly focus on LLTs, because that is where you will find the terms that you will use to code a particular event in a report that you want to capture in your database. So it is a hierarchy. I'll show the hierarchy to you in greater detail when we open up the MedDRA browser in a while. But let's look at the first level, which is the system organ class. Here are the 27 SOCs listed alphabetically in English. Now, for those of you who have a clinical background, physicians, physician's assistants, nurses, you will notice that many of these resemble the organ systems of the body. So you will have a cardiac SOC, for instance. You will have a SOC for musculoskeletal problems, a SOC for eye problems, a SOC for renal problems. Those are pretty straightforward and clinical. But MedDRA also has some unique MedDRA-specific SOCs as well for things like general disorders and administration site conditions, or injury, poisoning, and procedural complications, or product issues like I mentioned earlier, or social circumstances. When using MedDRA, your ability to be a good MedDRA user will revolve around how comfortable you are with MedDRA in terms of knowing what's in it. Because if you need to use a particular lowest level term for MedDRA, you're going to need to figure out which one of the 27 SOCs to look in for that particular type of term. So each time you go in MedDRA, you're going to learn something new. And as I said to you, we add between 1,500 and 2,000 new terms every 6 months. So even I, every time I look in there, will find out that my colleagues may have added a new term that I wasn't aware of in the last 6 months. But it may have been added because pointed out to us by one of our users, there was a glaring omission because we didn't have something in there that they needed for coding their cases. So you become a better MedDRA user the more you play around in the terminology and familiarize yourself with it. When people ask me how long it takes to be reasonably good with using MedDRA, in my experience, and again, my opinion, if you knew nothing about MedDRA, but you were diligent about trying to use it on a day-to-day basis and took training courses like our face-to-face training course on coding with MedDRA, my experience is that it's usually somewhere between 12 to 18 months before you're feeling completely comfortable with knowing how to maneuver around in the terminology. So anyone who's on the call today thinking that you can become a MedDRA expert in 2 or 3 days, I hate to burst your bubble, but that's not the way this is going to work, because again, over 100,000 terms within the terminology. And again, you can't know everything that's in there, but you have to have some idea of where to look. So I'm going to now show you again the hierarchy with a slightly different display. I'm going to look at one particular SOC, which is cardiac disorders. Now, when you look in the actual MedDRA terminology at the level below that, which is the HLGTs, what we effectively have done is to say, what kind of problems can you have with the heart? In other words, what are some of the kinds of cardiac disorders? Well, you could have, for instance, problems with the valve. You could have problems with the muscle. You could have problems with the sac around the heart, the pericardium, for instance. Or you could, for instance, have problems with arrhythmias, bad heart rhythms. And that is an example of an HLGT. Now, there are multiple HLGTs in the SOC cardiac disorders, but because of the limitations of the slide size, I'm only showing you one, which is cardiac arrhythmias. But under that HLGT, cardiac arrhythmias, we would then begin to have a series of buckets of different kinds of cardiac arrhythmias. And I'm showing you one of these HLTs, which is rate and rhythm disorders not elsewhere classified. If I look under there, I'm now going to start to see examples of specific rate and rhythm disturbances. And these would be at the preferred term or PT level. So one example here would be arrhythmia. Now, there are going to be several HLGTs and several HLTs, and depending upon the SOC, there could be hundreds of PTs within that SOC as well. But now we're looking at the PT level, and below each PT, you're going to find these lowest level terms, or LLTs. So here are 4 of the actual LLTs you're going to find under the PT arrhythmia. Now, here's a trick just to remember. If I give you any of the PTs in MedDRA, and I said there were 26,000 of them, if I give you any one of those 26,000 PTs, you can predict at least one of the LLTs, which is going to be underneath it, which is the PT itself. So it should not surprise you that under the PT arrhythmia, we have an LLT arrhythmia. But we also have other ones like arrhythmia not otherwise specified, or dysrhythmias. How about this one right here that's in red, which is other specified cardiac dysrhythmias? The reason that that LLT is in red on this slide, and literally is in red in the MedDRA browser, is because at some point in the past, the MSSO has decided to make this a non-current or inactive term. Now, we never, I repeat, never, and I'll repeat for the 3rd time, never remove a term from MedDRA. And so the point here is we decided to make the term inactive. And the question is, why would we have done that? Well, there are a number of reasons why we would make a term non-current. And I'm going to go through that with you. But the important concept here is this. If, in fact, we make a term non-current, it's because we have either added a term or multiple terms which provide a greater level of specificity and which we think are an improvement over the term that we have made non-current. But we never, never, never remove a term from MedDRA. Once it goes in, it may be made inactive, but we're never going to pull something out that has already gone into MedDRA. So let's talk a little bit more about this concept of non-current terms, and these are specifically LLTs. They're flagged in red at the LLT level. We recommend that you not use them anymore for coding purposes. Now, some of you will say, well, if you don't recommend us using them, why do you even show them? And that's because if you want to do some kind of retrospective analysis of aggregate data, if you want to look back at your data from 5 years ago, you need to have available to you in your analysis all of the LLTs that existed in MedDRA at that time. So why would we make a term non-current? Well, the easiest thing is we have rules for the MedDRA terminology. And if over time we add new rules for the terminology that make certain terms in there conflicting with those new rules, then we may need to make them non-current. But other reasons are terms that are vague, terms that are ambiguous, terms that are outdated. So if we were to have, for instance, terms related to a new disease that we don't know a whole lot about 5 years from now, when we know a lot more about it, it's pathology, it's pathophysiology, it's signs and symptoms, it's prognosis. It may be that we will take those original terms and make them non-current in favor of putting more up-to-date and current information. Other reasons why, if a term is truncated, and sometimes it's as simple as we misspelled the term when we put it in MedDRA. So, of all of these things that I mentioned as to why an LLT becomes non-current, I think the one that most people can appreciate and understand most readily is the idea of ambiguity. So this cartoon will only work for English speakers. But here are the letters I and O standing in the middle of the road, and they see X and L coming down the road. And I says, if they're Latin, they're consonants. If they're Roman, then it's the number 40. And O says, maybe they're from the garment district. And the bottom line here with ambiguity is when you use abbreviations, they create all the possibility in the world of ambiguity. So a lot of terms originally in MedDRA that were abbreviations, we realized that was an invitation for ambiguity, and we would have made those non-current in favor of putting a more descriptive term in. So let me just, again, reinforce this one more time, which is how would you code the following report? So you get a report that said, patient had MI. And if I asked you what MI stands for, you would tell me it stands for myocardial infarction. And you'd be absolutely correct, except when you're wrong, and you would be wrong. Because nothing in this report, patient had MI, provides you any context to know that MI stands for myocardial infarction. In fact, even if the report had come from a cardiologist, how do you know that MI stands for myocardial infarction as opposed to mitral insufficiency? And if it had come from a psychiatrist, it could mean mental illness. And if it had come from a surgeon, it could be mesenteric ischemia. So this is a good example of why abbreviations get you in trouble. They can be ambiguous, and we tend to make those types of terms non-current in MedDRA. Now, just shifting gears as well, I told you that MedDRA has over 100,000 terms in it. That's a whole lot of words. And not everyone who has to work with MedDRA is necessarily a clinician who understands any of that medical terminology. So every MedDRA term is also assigned an 8-digit numerical code. So for instance, the preferred term anemia in MedDRA has an 8-digit code, which is 10002034. And once that numerical code is assigned to anemia at the PT level, it's going to stay the same forever. It is non-expressive, meaning if I give you any one of these 8-digit codes, you'll never be able to tell me whether it's a respiratory or a nervous system or a cardiac term, because quite frankly, what happens is when we need to add a new term to MedDRA, we take the next available number. But what advantage does having these numerical codes provide for you? It helps you when you are dealing with colleagues who are not clinicians, such as data managers or biostatisticians, where rather than speaking to them in medical language, you could say to your biostatisticians, I would like you to go in our database and tell me how many occurrences of 10002034 we have. And that's how a non-clinician can help you in using data that is within the MedDRA database. So it's another currency, so to speak, that you can use in communicating not only internally about MedDRA, but you could use it for electronically transmitting data to another source, including a regulatory agency. Okay. Another concept I want to present that's important in knowing how to use MedDRA is the concept of multi-axiality. And to introduce multi-axiality, I show you this quote from Sir William Osler, who is considered by some to be one of the original fathers of modern medicine. And William Osler said, "He who knows syphilis knows medicine." And when I ask, what does that mean? Sometimes people land directly on the answer. Syphilis is a disease that can affect multiple organ systems: heart, lung, kidneys, skin, brain. And so if you were fairly competent and knowledgeable about syphilis and the way that it affects the body, you probably have a pretty good clinical view. And the other point of this as well is syphilis is a disorder where if I said, well, where will we find all the terms related to syphilis? Which sock? The answer is it won't be in just one sock. There will be relevant terms in multiple socks because, again, as we said, it can affect multiple organ systems. And that's where the concept of multi-axiality comes in. That when we look at the 26,000 plus PTs in MedDRA, some of them need to be in more than one sock. If I asked you, what does HIV do to the body? What systems involved? You would say multiple systems. So it may be that we have a concept that's not in one or two or three, but may be in several different socks within MedDRA. Now, this is the concept of multi-axiality, that PTs can be in more than one sock. And this is not a trivial concept either, because about 40% of MedDRA PTs are multi-axial, meaning they're in more than one sock. So this allows us a few things. It allows us, when we go to data retrieval and presentation, to look at our data sets in a number of unique ways. It also allows us to classify our data in different ways. But it also creates a little bit of a dilemma for us as well. Because if we have a PT in multiple socks within MedDRA, and we begin to start counting up cases based upon how many cases we have at a PT level in MedDRA, if we have that same PT multiple times, there's the risk when we do aggregate analysis, we will double count or triple count or quadruple count for that matter. So how do we get around that? Well, we get around that by when a PT exists in more than one sock, the MSSO will decide which one of those socks is going to be the so-called primary sock. And any other socks that it appears in will be secondary socks. And that is how, when you begin to look at your data in aggregate form, if you look at PTs, looking at them only underneath a sock, which is their primary sock, that's how you're going to get around the dilemma of double and triple counting things. But this assignment of primary sock by the MSSO is non-negotiable. You don't get to change things and move them around. It's part of the standardization, and it is why when you get the version of MedDRA from us, you should not make any attempt to change where things are in the terminology. So let me give you an example, a couple of examples of this multi-axiality. Here's the medical concept of obesity cardiomyopathy. It actually appears in two socks. One of the socks you will find it in is in cardiac disorders. And we have made the determination that the primary sock would be cardiac disorders. But it is also, because obesity is a metabolism and nutritional concept, it also appears in that sock, and that is a secondary sock for this medical concept. Let me give you another example. Influenza is in two socks: infection and infestations, as well as respiratory, thoracic, and mediastinal disorders. The MedDRA rules dictate that this particular concept will have as its primary sock infections and infestations, and if there were a third and a fourth and a fifth sock, by definition, those are going to be secondary socks. Now, I'm not going to go into the specific rules of how this gets done. That's part of any one of the coding courses that you take, either the webinars or the face-to-face. Again, I'm just helping you to understand the big ticket items related to the use of MedDRA. So at this point, I'm going to stop and ask Sarah if I've gotten any questions so far from the audience.
You do not.
Okay, that's either very good or very bad. I'm going to assume it's very good, and let's move forward. Let's talk a little bit more about MedDRA maintenance. Okay. MedDRA needs to be maintained, and I told you that the MSSO is the organization responsible for the maintenance. You as subscribers are allowed to submit what are called change requests, where you send us a request that says, hey, I think you blew it. I think you put this particular PT in the wrong sock, or I don't think it's in the right place in MedDRA. Or more commonly, you'll say, you don't have a term in MedDRA for such and such. Please add this term because we need it for coding. Each organization that is a MedDRA subscriber is allowed 100 change request submissions a month. Those change requests are reviewed by a panel of 3 international medical officers, 3 of my colleagues within the MSSO. And they diligently meet several times a week looking at all these change requests, deciding whether they merit being put in MedDRA, and then making the determination of where they should go in MedDRA, what their primary SOC should be, and if they're multi-axial PTs, what the secondary SOC should be. Now, if you submit a change request related to either the PT or LLT levels, the 4th and 5th levels of MedDRA, these are so-called simple changes, and you will get a response back from us in 7 to 10 days. The responses will either be, we approved your request, we approved it but not as requested. For instance, if you have 2 words in your change request and you capitalize the first letter of each word of your request, that violates MedDRA naming conventions. So we'll just change the name by turning the first letter of the second word into a small case letter. So in other words, we approved your general idea, we just tinkered with it so it met our conventions. So that would be the second example of approved but not as requested. The third thing that would happen is we would give you an outright rejection where we say we rejected your change request, but we always tell you why it was rejected. And then the last possible response is we suspended your request because either we need more information from you or we need more time to think about it. But suspended requests are typically fairly rare. The IMOs or international medical offices are very good at taking care of most change requests the first time they look at it. However, if your request is at the HLT, HLGT, or the SOC level, this is a so-called complex change, and we don't have a clock that runs that will guarantee you a result. Instead, what we do is we post these complex changes to the MedDRA website and ask you as users to evaluate them, help us evaluate them, because they tend to have the potential to significantly change the existing hierarchy. So when we start talking about changing HLTs, HLGTs, and SOCs, a lot of things can happen. And therefore, we only do that once a year of asking you about complex change requests. And for those of you who pay attention to emails, we sent out an email today telling you about the change request process and giving you time to do your reviews. So MedDRA gets updated twice a year, March 1st and September 1st. The March 1st update is a so-called complex release, where that means that any of the 5 levels of MedDRA could be changed. So in March of this year, we released version 27.0. And just several days ago, on September 1st, we released version 27.1 in English. And that is so-called simple release in that all of the changes are limited to the PT and LLT levels. Now, this tool for submitting change requests is called WebCR. You go on this URL and it will allow you to submit a change request as a MedDRA subscriber. There are some rules related to this, however. The request must be in English. They can be related to a MedDRA term, to a standardized MedDRA query, or you can submit a change request because you believe that the translation into one of the available MedDRA languages has been incorrect and ask us to take a look at it. We updated this tool, this WebCR, to make it more user-friendly. The interface is easier for you to enter the information you want to send to us. When you submit a change request, you're going to get immediate confirmation that we received it. You also have the ability to hold off on submitting your request and look at it several days later, and you may decide that you no longer want to submit it, but you can hold it and submit it at a future time. And it also allows you to look at change requests all the way back to version 5.1, because it may be that the change request you're submitting has already been submitted 12 times, and each time it was rejected for the same reason. And you look and you see the 12 rejections and you say, oh, I get it. Yeah, it makes sense. I'm not going to waste time submitting this and have this be the 13th time that it gets rejected. So this is what the interface looks like. You need your MedDRA ID and your change request password in order to submit these things. And what happens is it takes you to this tool. You then are able to submit information. In this particular case, and I apologize for the size of the screenshot, but this would be someone who is submitting a request for a new LLT that they believe should be in MedDRA. Now, we ask you also to provide a justification for why you're making the change request. And this second bullet is very important. The more justification and the more support documentation you provide, the better the chance it's going to be approved. For instance, if you just came back from an international congress on liver disease, and one of the presentations was about a brand new liver disease that was just discovered in the last 2 months, and you submit a change request saying you don't have this disease in MedDRA, here's a paper from the conference I attended, that's a pretty good justification with pretty good support documentation. And it's very likely that's going to be put into MedDRA when the next release comes out. On the other hand, if you want to put a term in there and your justification is, you need to add this to MedDRA because I like it, I'm not so sure that one's going to work. So again, you help your case by how much documentation and justification you submit with a change request. One other flavor of how you can communicate with us. Sometimes you're not communicating with us about a specific PT or LLT, but stepping back and looking at the entire terminology, you look and you see that we have been inconsistent in the way that we have been dealing with a concept within MedDRA. This is then a so-called proactive maintenance request. Let me give you an example of what I mean. Someone at a point in the past looked in MedDRA and said, when I look at the PT level in certain SOCs, you have the hemorrhage concept as PTs, and you have hematomas as LLTs. When I look in other SOCs, you did the exact opposite. The hematomas were the PTs, and the hemorrhages were at the LLT level. Well, that's a big inconsistency. And it's not just in one place, it's multiple places. And so when we get those kind of high level, you kind of blew it, you weren't consistent here. We take these proactive maintenance requests very seriously. And again, the more justification, the better. And in the past, we have implemented a significant number of these proactive maintenance requests. Because again, when the IMOs do their job, they try to be consistent. But because over the course of time with multiple IMOs who work for the NSSO, we can have certain inconsistencies. So this is what the proactive maintenance allows us to do. You send us an email with as much justification and you say, at a very high level, I think you need to look at this. And we will look at those as well. And we value that kind of input from you. Okay. Any questions at this point, Sarah?
We do. Oh, and then we just got another one. The first one was, hi, where can we find the full list of codes?
So we're going to get to that in a future slide. So you're a little bit ahead of me.
Perfect. And then the next one was, it said, on the slide showing the SOCs, MedDRA has taken general disorders and administration site conditions under a single SOC. However, isn't general disorder a system and administration site conditions local?
No, we will take a look, though, in that SOC when I open the browser, and you'll get a flavor for what we're talking about there. It's a combination of things there. It can sometimes be signs and symptoms. It can sometimes be body system things. And sometimes, depending upon the circumstances, It may relate to the device, the product, etc. So we'll take a look at that particular SOC because there are some interesting things in that general disorders SOC that you need to know that they're there, including the MedDRA terms related to fatal outcomes should you ever need to code a death that has occurred with your product. So now let's move on and talk about some tools that we make available to you. I'm not going to go into tremendous depth, but they are tools that you should know about. And we have all kinds of teaching things to help you with these various tools, including not only webinars, but also video casts, etc., that you can look at to get even more proficient. But the very first one I want to mention is the MedDRA browser. So the MedDRA browser comes basically in three forms. We have a web-based browser where the information is in the cloud, and by using the proper credentials, you are able to access a web-based version of the MedDRA browser. The second version is a so-called desktop browser. And this is one where you go on the MedDRA website, you download a browser, and then you download specific files that you want to load into that browser. Now, the difference is going to be that because the web-based is in the cloud, it's in real time. So changes that are occurring in the browser, depending upon how you view the web-based browser, you're able to see fairly recent information. On the other hand, the desktop browser tends to be static because you are loading files that were loaded in there at the time of a MedDRA release. And we're going to look at both of those, or I'll show you the desktop. That's what I tend to work off on, but that's just my personal preference. But effectively, the two are similar in appearance, and I will say something as well about an overall facelift of all of our browsers that is in the works right now. The third one I want to mention, and I'll just say this as we say in English, tongue-in-cheek, at some point in the past, someone said, you need to have a browser that I can see on my phone. And when I asked, you hear people say, well, if I'm on vacation, I want to be able to open up my phone and look at the MedDRA browser. And my immediate thought was, boy, I feel sorry for that person, because if you're on vacation, why would you want to be looking at codes? The other point of this as well is once you have access to codes on your phone, then just be aware you can't use the excuse, I couldn't access the browser. So we provided that as well for those who are kind of compulsive about where they need to work and when they need to work. And it's another option for you as well. So let's talk about the browsers again. Each requires a MedDRA ID and password. It allows you to search the terminology. It also allows you to look at these standardized MedDRA queries. It supports all of the available MedDRA languages. It has a language-specific interface that you interact with. So if you speak French and would prefer a French interface with all of the words that you're looking at being in French and being able to enter your information that way, MedDRA allows you to do that with the browser. It also allows you to export results from the browser as well. The browser is basically a way of giving those of you who do not have a multi-million-dollar data management tool at your disposal, like at a big pharma company, but rather you are a small operation, you're taking these files that you get as part of a MedDRA release and loading them into a browser that allow you to be able to recreate the entire MedDRA terminology. Now, this is an important distinction between the first two browsers I mentioned, which is the web-based and the desktop. I said to you that the web-based browser is in the cloud. And because it is in the cloud, you have the ability in the web-based browser alone, not in the desktop, because again, it's a static platform. But in the web-based browser, you have the ability to change the interface to be able to get a look at what are called supplemental terms. These are terms that the IMOs, the International Medical Officers, have approved for the next version of MedDRA. So for instance, right now, the IMOs are looking at change requests, trying to evaluate whether they belong in version 28.0, which is coming out in March of 2025. If you go into the web-based browser and you look in this supplemental view, you'll be able to see those terms that have been approved for that upcoming version. Now you'll say, well, why would I want to see that? Well, maybe you submitted the change request and you want to see whether your change request was approved. Or maybe you are a very large pharma company and you want to get some look at what are the upcoming changes that I'm going to have to deal with in March, because if it involves any kind of recoding on your part, you may want to get an idea of whether this is going to be 1,000 times I need to recode or 10,000 times I need to recode. So in a sense, you're getting a look at allocating resources before the fact. Now, both of them allow you to not only look at the primary SOC allocation, but also the secondary SOC allocation. They have a couple of tools built into them that do things like allowing you to run the existing standard measure queries against a database that you upload. And for those of you who are computer geeks, you can use these for various kinds of searches using Boolean language like includes, does not includes, not, or, and all those other kinds of things as well. So this is what the web-based browser looks like, the interface of the web-based browser. And for the person who was asking where you find the codes, just hold on a minute because I'm actually going to open up the desktop browser and show it to you. Now, another tool that we have is this so-called MedDRA version analysis tool, or MVAT tool. Here's the URL for it. It's free to all of our subscribers. What it allows you to do is be able to compare any two versions of MedDRA. And that way, when we release a new version like 27.1, and you want to know, well, what changed from version 27.0, you can use the MVAT tool to compare the two of them, and get a detailed spreadsheet of these are the new PTs that were added. These were the terms that had their currency change, either going from current to non-current or non-current to current. These are changes to SMQs. These are PTs that were moved to a new primary SOC. All that can be done through the MVAT tool. The MVAT tool has a user interface that can be changed for the various MedDRA languages. You can also, again, get output using the MVAT tool. And you can also look at supplemental changes as well as look at secondary SOC assignments. So this is what the MVAT tool looks like. And I was going to do a demonstration of the MVAT tool, but I think in the interest of time, I will move past that and concentrate more on showing you what the browser looks like. And then if we have time at the end, if we're not running close to the allotted time, I'll go back and show you the MVAT demonstration. So again, I'm going to skip over this. So if you ask what people use MedDRA for, 99% of the time it's for coding. So let's spend most of our time talking about coding. So the first thing is you're going to code. And the question is, what rules should you be following when you're coding to know that you're selecting the right terms? And these rules are called coding conventions. These are typically written guidances or sets of principles that you would use to make sure that when you are coding accurately and consistently. If you have coding conventions, for instance, if your organization has written coding conventions of this is how we code at ABC Pharmaceuticals, then it allows you to have harmonious treatment of your data, regardless of which one of your coders is doing the coding. Coding conventions also can help you with what do you do when you have information in a report that is misspelled, or it's an abbreviation, or it's an acronym. What do you do when you get these combination terms where it says due to, for instance, fever due to influenza? What are you coding? Are you coding fever? Are you coding influenza? And sometimes your coding conventions will take any kind of freedom away from you and have absolute rules that will say, anytime we get a report of chest pain, go back and query the site or the source to see whether it was cardiac in nature. So these are the kinds of things that organizations do in terms of creating coding conventions. And I think it's a good idea to have them in writing, because if you ever were audited for why you coded a certain way, the first thing you need to do is to be able to produce the document off of which you work. And if you don't have a written document, I'm not sure that that audit is going to go very well for you. Other reasons why you need coding conventions, because your coders may have different medical aptitudes. Some may be doctors, nurses, and physicians' assistants. Some may be people with a background in American history who just happen to have worked for your company for 20 years as a coder and know about as much about a particular product as any physician, nurse, or doctor, or excuse me, physician assistant, doctor, or nurse within the organization. The other reason you need coding conventions is it leads to consistency. And even if you are using these softwares called autoencoders, this is just a machine or software's attempt to try to code. Some human being better check to make sure that it's accurate. Otherwise, you could end up sending things to a regulatory agency that are quite embarrassing. So we provide support documentation that is called points to consider documents. And we have one related to term selection, which is the whole coding process. This is what the cover page of the MedDRA term selection points to consider document looks like. It is ICH endorsed guidance that is used by industry and regulators, with the objective being, we're giving you some principles, we're giving you some guidance, and if you follow this, you're going to be consistent and accurate in the way that you code. If your organization does not have its own written coding convention, as MedDRA subscribers, you have our permission to use our PTCs as your coding conventions. The PTC document itself is developed by an ICH committee. It is updated annually in March of each year. We have complete versions in English, Japanese, Chinese, Korean, Spanish, and Russian. We have condensed versions of this term selection PTC in several other languages that are listed here. And they are available on not only the MedDRA website, but on the Japanese Maintenance Organization website as well. So let's talk about some general principles of coding. I told you that when you are coding, you are trying to find LLTs. You have 88,000 LLTs. You're trying to find the one that is a current LLT that most accurately reflects the verbatim that you're trying to code. So again, select the LLT that most accurately reflects the reported verbatim information. So suppose you get a report of abscess on face. You can go in MedDRA and find that there is an LLT called abscess. But if you do that and use that as your code, you have been very, very lazy, because what you failed to consider is that this said abscess on face, and by choosing abscess, you've lost the anatomic specificity that was in your report. And that might be quite important. For instance, you could have an abscess on the skin of the neck, or a brain abscess, or a facial abscess, or an abscess of the lung. So what you should have done in the interest of being a good coder is dig a little bit deeper, and you would have found there's an LLT called facial abscess. And that is the right LLT to have chosen, because it captures not only the pathology, which is an abscess, but the anatomic location. And why would you not include information that is available to you in your verbatim if you can find an appropriate code within MedDRA? So again, remembering that when you code, you only want to use current LLTs. So the key to quality data, and data is key here, the key to quality data, especially when you go out later on to look at it, to analyze it or write reports or submit a new drug application, for instance, in the United States, is you need to do a good job of coding. And the thing to remember as a coder is this: to be an accurate coder, you can take the easy path, picking the first thing you come across in the first 10 seconds at looking at MedDRA, and it's simple, but many times it's wrong and you fall off the cliff. Sometimes you need to do a little bit of work and look through MedDRA and the 88,000 LLTs more thoroughly. It can be a little bit more complex, but what you're really interested in is getting it right. If you don't get it right in the very beginning, there's no way when you go in to look at that data 6 months or a year from now in a database that you can recreate something that you failed to put in there. So you're going to select terms for all reported information, adverse reactions, adverse events, regardless of causal association. You're going to select terms not only for diseases and signs and symptoms, but for device-related things, product quality issues, medication errors, all those things that I showed you within that blue circle, if that is the mandate of the regulatory authority in the region that you are trying to develop your product. So what might you do in coding? Suppose you get a report of throbbing above the temple, aching all over the head, pulsing pain in the head, really bad headache or headache. Those are all descriptions that you can get in a patient report. What would be the best LLT to have selected for those kinds of reports? The term headache. How about you get a report of infection in lungs and you look for the term infection in lungs in MedDRA and you don't find it as an LLT. With a little more looking, you will find lung infection, and that's the right LLT. And sometimes in a report, you're going to code more than one LLT. Patient took drug A instead of drug B and experienced hypertension. So there was, first of all, a problem here with administration in that the patient took the wrong drug. So one concept you would code was wrong drug administered. And then as a result of taking the wrong drug, there was a side effect, which was hypertension. And you coded that as well. This slide and the next one are just going to show you the index of what's in the PTC for term selection. I don't expect you to memorize this, but I would like you to look at it at some point, just so you understand that we have guidance on a number of topics. For instance, breastfeeding. Depending upon the types of products you work with, maybe once or twice a year, you're going to get a case come across your desk of a baby who's been exposed to your drug through breast milk. I don't expect you to memorize what's in the PTC about breastfeeding, but it would be a good idea if you knew there was something in there, so at that particular time, you could refer back to the PTC and see what it is that we said. You may have a drug that is used for something fairly benign like toenail fungus, and you don't see cases of suicide and self-harm. But maybe once a year, somebody using your drug, you get one of those terrible reports of a suicide, and you probably need to look at the PTC to see what it is that you're supposed to do when it comes to coding those kinds of events. And that's why it's a good idea to be familiar with what's in the PTC on term selection, and to use the conventions of the PTC on term selection. Now, I'm just going to quickly show you that the PTC for term selection is one of several PTC documents. We have documents for term selection, the one I'm talking about, in the full version in these languages that I mentioned, a condensed version in other languages. We have another one for data retrieval and presentation, which is guidance on what you do with MedDRA-coded data when you want to pull it out, analyze it, evaluate it, present it. And we also have another document called the companion document, where you will find more detailed information on some specific topics, including data quality, medication errors, and product quality issues. And we have a fourth section being added to this companion document later this year on manufacturing and quality system issues. And I will show you on the MedDRA website at the end of the webinar where to find these PTC documents. Okay, I'm going to open up the browser and spend about 10 minutes just showing you what it looks like, and then give you some examples of how you might go about coding with it. I'm not trying to make you an expert coder. If you want more work on coding, then you should take either the basic coding webinar, the advanced coding webinar, or a face-to-face coding with MedDRA class. But for my demonstration, I'm going to open up the browser for you. Hold on 1 second for me. There we go. Okay, so here is the browser. This is the desktop browser. Mine is set to show as the default language version 27.0 of English. When you look at the browser, you're going to see a number of things on it. I want you to understand that the entire look of the browser is going to change between now and the end of the year. One of the comments that we got was, there's a lot of stuff on that browser page and it's a little confusing. So the new interface, when it is released, will be an attempt to make it a little easier on the eye, less on each page, and have some things hidden behind that you click on a certain thing and it takes you to some of this additional information. It's also going to allow you to customize the look of the browser to fit the way that you use the browser. But across the top, we have a banner that tells me I'm looking at the English version 27.0. It's telling me about other places I can look for everything from concept descriptions in MedDRA, which are about 70 or 75 concepts the way that MedDRA views them. For instance, how does MedDRA view the concept of underdose or overdose or abuse or misuse? So if I click there, it's going to take me to the concept description. And I can scroll down and see how MedDRA is viewing a particular concept that's on this list. And that's important for you to know about, because if you and MedDRA are looking at a concept a different way, then it may not give you what you want. You have other things you can do, including clicking on a user guide. These are some tools that you would learn more about if you took either one of our SMQ courses or if you take one of our data analysis courses. But to the earlier person of where do I find all these codes? Here are the 27 SOCs alphabetized in American English, starting with blood and lymphatics and going all the way down to vascular disorders. And what I can do is I can click on any one of these SOCs. So if I click on the SOC cardiac disorders, it's now going to show me the HLGTs that are underneath cardiac disorders. And as I said, these are big baskets of what kind of disorders can we have with the heart. We can have neoplasms of the heart, for instance. We can have endocardial disorders. We can have heart failures. We can have valve problems. We can have cardiac arrhythmias, pericardial disorders. If I select any one of those, let's say I take cardiac valve disorders, now I'm seeing the HLTs, aortic, cardiac valve disorders not elsewhere classified, mitral pulmonic, and tricuspid. If I click on HLTs, now I'm going to see specific aortic valve problems, the kinds of medical concepts, right? That it's incompetent, that it prolapses, that it ruptured, that it's thickened, that it's bicuspid. And if I select any one of those PTs, I begin to see LLTs, which is the level you want to be at when you're coding. You want to select LLTs. Now, I'm going to anticipate a question. Someone's going to ask me, how come some of the boxes are green, some of the boxes are red, some of the boxes are blue? That's out of the scope of this webinar. You would really need to be doing one of the coding ones, and we'll tell you what the nomenclature is of why we have these different colors for different types of terms here. But this is just to show you what happens when you begin to drill down. You will see one thing that I mentioned already, which is here's LLT in red with a red box around it. And you'll recall from the earlier slides that we said that's what we do when in fact we have made a term non-current. And so this term, aortic valve disorders, was made non-current in the past because you can see we have added other terms which provide a greater level of specificity. But in terms of why is this green? Why is that blue? Why is that red? Again, that's another scope that we wouldn't be able to cover in today's webinar. This is supposed to be more of an overview. But you can, in fact, take any one of these SOCs, open them up, and do the same thing, and get down to lower levels of MedDRA. Here are reds and greens and blues in here, and at the bottom, you're going to see LLTs as well. So this left panel here is a way of looking at the entire MedDRA hierarchy if you wanted to. The center part here is where you would do a search within MedDRA. And what you basically would do is you want to type in a phrase here to see if it's in the MedDRA hierarchy and where is it in the MedDRA hierarchy. So suppose I got our case report that said the patient had a cluster headache. The patient had a cluster headache, and I wanted to code as my LLT cluster headache. I need to decide, does cluster headache even exist in MedDRA? And if I type in cluster headache and I search, guess what? It tells me that at an LLT level, I do have a term called cluster headache. And I could select that term and ask it to take me to the browser, and look what it's going to do. It's going to go over to the hierarchy, open up the hierarchy, and show me exactly where cluster headache is within the MedDRA hierarchy. So we're not going to go through all the features of how you would do a search in here, but this was a so-called bottom-up search where I thought I knew what the LLT was. I typed it in, and lo and behold, I found evidence that it does actually exist as an LLT. And now I'm able to see where it is here in the MedDRA hierarchy. So that's one way that you use the browser. Now, right now I'm highlighting cluster headache, and you will notice that this panel down here has appeared. This panel is designed to give me more information on that term cluster headache. It's telling me that cluster headache is under the PT cluster headache, that it's under that HLT, which is under that HLGT, and it's in the nervous system disorders side. So this is enhanced information. By having selected it here, I see more information here. The other thing I can do is, if I am searching for something in MedDRA, in this panel here, I'm seeing all 27 SOCs. What if I'm not interested in seeing the output from all 27 SOCs? I can just select the specific SOCs that I want output from. Now, the second way that you can use the MedDRA browser to search, we just did a bottom-up search. How about a top-down search, where I am arrogant enough to think that I know which SOC to look in for a concept? I'm pretty confident that I know what SOC is going to be. Let's do an example. Suppose I wanted to code a case of the patient had a myocardial infarction. I want to code myocardial infarction, but I want to be sure it's an LLT in MedDRA. So if I look at the SOCs and think about it a while, I might say, I think it's in cardiac disorders. And I click. And now I see all of these choices here, including endocardial disorders, heart failures, myocardial disorders. And if I asked, which one of these HLGTs do you think I should open? 9 out of 10 times, people are going to say, well, look for myocardial infarction and myocardial disorders. And I can assure you, if I open up that HLGT, I'm never going to find myocardial infarction. And why am I never going to find it? Because part of using MedDRA, as I said, is you have to have some clinical background to know what you're looking for. Because the point is, in a myocardial infarction, where part of the heart muscle is dead, the problem wasn't the myocardium or the heart muscle. The problem was you got blockage of the coronary artery that sat on top of it. So myocardial infarction is a result of a coronary artery problem. Therefore, to find it, I would have to have looked under the HLGT coronary artery disorders. And then it gives me 2 potential HLTs, and I would have to know that a myocardial infarction is an ischemic disorder. And once I do that, it takes me to PTs, and one of the PTs is myocardial infarction. And if I open that, lo and behold, one of the available LLTs is myocardial infarction as an LLT, and I now know that I can use it for coding. So the difference was with cluster headache, I typed in what I thought was the LLT here and verified that it existed in MedDRA. But for the myocardial infarction example, I did a top-down where I started with cardiac disorders and tried to drill down and have proven to myself that myocardial infarction is actually an LLT. And look who else is there. Our good old friend MI, which is non-current because, again, the initials MI don't tell us that it is a abbreviation for myocardial infarction, because as we said, it could just as well have been mental illness. But I wanted you to see the browser because this is what you might work in as a coder trying to figure out how to code something. Even if you have an autoencoder that does your work for you, sometimes the autoencoder is going to say, I don't know how to code that. And now someone has to manually go in MedDRA and try and find an LLT. And this would be the way you would use the browser to do it, either as a bottom-up or as a top-down search. So that's what I wanted to show you about the browser. Okay, let's move on. You've put all of this nice information in your database. You have hundreds of thousands of data in your database. And now it's time for you to try to figure out, so what does my drug actually do? Is it associated with something like multiple sclerosis, or is it associated with certain kinds of cancers? Because sometimes you lose perspective of what your drug does, especially if all the data is not coming through your computer and across your eyes. So you may have 50 colleagues in your organization do the same thing that you do, and you don't see what they see. So you only see the limited amount of stuff that comes across your desk. You don't have the totality of what's in there. But when it comes time to look at the entire database, now you need a way of trying to figure out what might my product be associated with, because it may have a big impact on what you have to put into the labeling or prescribing information. Or it may have a big impact on whether you even decide to try to market the drug at all. What if you are, as I said, developing a drug for toenail fungus? And it turns out in looking at your data, you have a bunch of cases of irreversible aplastic anemia. For those of you who are not physicians, all you need to know is aplastic anemia is a bad thing. And if it's irreversible, that means that even if you stop the drug, it doesn't get any better. So if you were to see a certain number of cases of aplastic anemia with potentially associated with your drug, and your drug is for toenail fungus, as a company, you may decide this dog won't hunt. There is no sense in spending any more money trying to develop this drug because it's not going to get approved. And even if it gets approved, any intelligent person is not going to take the risk of getting aplastic anemia. They're just going to go to the drugstore and get some tea tree oil and keep it moving. So standardized measure queries are a tool that we, the MSSO, provide to you to help you look at your data and try to get an understanding of whether you have big, bad, terrible stuff that may be associated with your drug. And in creating SMQs, as they're called, we take terms from one or more of the MedDRA SOCs that would be characteristic of the condition of interest. So, for instance, if I were trying to develop an SMQ for multiple sclerosis, I would include MedDRA terms for signs and symptoms of MS, the diagnosis of MS itself, as well as other diagnoses that might be used for MS, like demyelinated disease, other syndromes that are demyelinated, physical findings of patients who have MS, double vision, ataxia, imbalance, tremor, laboratories like high protein in the cerebral spinal fluid, or plaques on an MRI of the brain. Anything that might be characteristic of MS, including the disabilities that one might have with MS, or what one might have to do from a lifestyle point of view if they had MS, like using a wheelchair. So we would use all that information in creating this query. Queries are constructed in MedDRA at the PT level. So in making an SMQ, I would take medical concepts that are characteristic of MS, and I'd put them in my query. And by definition, all of the subordinate LLTs underneath those PTs would be in the query as well. And then to actually use the query, one would take your database. Whether it's a clinical trial database, a safety database, it doesn't matter. Because it has MedDRA coded data, it's full of LLTs. And as I said, in creating my query, I put in PTs with all of the subordinate LLTs as well. So then I have something called a query tool. And I'm waving my hands right now because you can't see me doing this, but I'm waving my hands because this is where it gets a little soft from the perspective of if you have a multi-million-dollar data management system at your disposal, you're going to have a query tool built into it. But if you're working at a pharma company with only 20 people, you may not have one, and we provide other tools that you can use that effectively create a query tool for you. But what I do is I take my MS query, I put it in the tool, and I run it against my database. And every time an LLT from my query is found in my database, by some mechanism, the tool says hit, and it tells me you need to pull that case out because it's potentially a case of MS. And someone who is a learned person needs to look at it and try to figure out what you have there. But that, in a nutshell, is how queries work. So when it comes to data retrieval and using queries and anything else that has to do with presentation, we have a PTC that I mentioned in an earlier chart. We have the one for term selection. We have one for data retrieval and presentation. And this will provide you guidance on data analysis. Now, here's the important thing I want you to understand about SMQs. We have 110 SMQs currently available to you. Look, and this is a sample of some of them. Look at the kinds of medical conditions that we have chosen to make SMQs for. Agranulocytosis, anaphylaxis, central nervous system vascular disorders. Translated, that means stroke. Hypersensitivity, severe cutaneous adverse reactions. That's bad stuff like Stevens-Johnson syndrome, shock, osteonecrosis, your jaw disintegrating because you take certain kinds of medicines. My point here is these are serious conditions, the kinds of conditions that in doing the risk-benefit analysis of whether to develop your product or not, you have to decide whether the risk of developing one of these bad things is worth it. Perhaps the risk of osteonecrosis is worth it if your drug is for some life-threatening cancer. But as I said before, if your drug is for something like bad breath, you probably don't want to run the risk of having convulsions taking a drug for bad breath. So we try to be very selective in creating SMQs to make sure that they are high-ticket items that have real value for you as MedDRA users. So let's talk about the SMQs, but again, just overview because we have SMQ courses and SMQ webinars. The benefits of SMQs is they can be applied across multiple therapeutic areas. They have validated search logic. They're standardized using MedDRA terminology. And if you run the same SMQ against the same set of data, you're going to consistently get the same result. And here's the best part about SMQs. We develop them, we test them, and we maintain them. So even though an SMQ may have been released 5 years ago, several times a year, medical officers in the MSSO, like myself, look at new terms added to MedDRA and decide whether they need to be added to existing SMQs. So the SMQs are always kept up to date. All you need to do is use them. What about limitations? Well, the limitations are obvious. We don't have an SMQ for everything because, as I said, we tend to focus on clinically important problems that could cause you to have difficulty getting a drug on the market or keeping a drug on the market. And they always require maintenance on an ongoing basis. So let's talk a little bit in practical sense about where you might use SMQs. Let's say you are on the development side in clinical research, phases 1, 2, and 3. You might use SMQs because you don't really know the safety profile of your new chemical entity. And you decide on a routine basis to run your constantly expanding set of safety data against SMQs to see if there's a signal of something that may be associated with your drug. Or it may be that you are developing the 12th drug in a particular therapeutic class, and the other 11 already have a well-developed safety profile. You can run SMQs that are reflective of those known side effects against your drug to see if it resembles all the other ones, or if somehow it's unique and doesn't have some of the things that are in that class. And for those of you who work the veterinarian side of the things, if you have data from preclinical testing, it may be that you think that something from mouse or rat studies is predictive of a risk in humans, and use that to decide what SMQs you're going to run. And then when you get your product marketed and it's in phase 4, you still need to know about the safety. Because again, if you had an event associated with your drug that only occurred in 1 out of 1 million people, but you only exposed 3,500 patients to your drug to get it approved, it's probably going to be months, if not years, before you see your first case. So you're constantly looking at safety surveillance, even for marketed products. And you can use MedDRA to retrieve cases of suspected or known signals. You can use it as part of a signal detection strategy. You can use it for single case alerts for a particular type of entity. And you can use it to help you with your periodic reporting that are part of your annual reports that you submit to regulators. So at this point, most of you have a 100192111, which is the MedDRA code for headache. What I am going to do, looking at the time, is very briefly just go back and demonstrate that MVAT tool for you, because I think that's important for you to know what it does for you. And in order to do that, what I want to do is start out by showing you just a set of data. And this data is for my pharmaceutical company, Dave Pharmaceutical Company. And in reality, I'm a pretty selfish guy in that the only thing I care about are things that are going to potentially affect my product. So I care about these 200 some rows of data. Well, this is how the MVAT tool is going to help me. If I were to, and let me do this a particular way. If I open up the MVAT tool, here's the MVAT tool. Mine is set, it's for a default setting of English. It's comparing the current version of MedDRA, which is 27.1 in English as of September 1st, to the version immediately preceding it, which was 27.0, which was released in March. Here are the 27 SOCs alphabetically. One of the things that it allows you to do is to do an analysis of comparing one version of MedDRA to another. So suppose I want to compare version 27.1, the current version, to version 24.0. And I want to see what's happened between this release, which was in early 2021, if my math is correct, versus now here toward the end of 2024. I run this version report, and it's going to compare those two versions of MedDRA. Now, it's going to take a little bit of time because that's a lot of stuff to look at. But the reversion report is going to tell me, here's what's different. And if those changes that have occurred are relevant to my business, then I need to be aware of it. So it's telling me I compared those two versions, and over that period of time, there were 84 promotions, meaning that 84 terms that were LLTs were promoted to PTs. And I can click here, and it will show me those 84 terms. It will tell me that this was the LLT, and this is the PT when it's promoted, and it tells me what its primary SOC is, etc. I can look at LLTs that are under a different PT. So if I ask for the details on that and click on it, and it'll take a minute to do that, it's going to show me what PT it used to be under in version 24 and what PT is under now in 27.1. It doesn't tell me when over that 3.5-year period of time it occurred, but it's telling me it has now moved to a new PT. I can do that with any of these sets of data in terms of comparing the various things that I see here. Now, the second thing that I can ask it to do is to look up a specific term. suppose I put nasal, spell it correctly here, nasal sinus drainage. Forgive my typing, that's not my strong suit, but it's going to auto-populate. I'm going to ask the MVAT tool to tell me the entire history of nasal sinus drainage in MedDRA. It's going to take a minute or so, and then it's going to give me the results. And here's what it has decided to tell me. It is telling me that the term nasal sinus drainage was put into MedDRA in version 4.0. So we're talking 23 years ago. When it was put in, it was a PT, and it was in the SOC, respiratory, thoracic, and medial spinal disorders, and it was given this 8-digit code. And it looks like we left it alone for about a year. And then a year later in version 5, we demoted it and made it an LLT under a new PT called paranasal sinus hypersecretion. We demoted it and we made it non-current, as you can tell, because LLT is in red with a red box around it. Well, somewhere after that was done, we get a change request from one of you that says, boy, are you people stupid. Nasal sinus drainage is not a respiratory term. It's a surgical procedure. And we thought about it and we said, gee, you're right. So in version 5.1, we moved it out of that SOC and put it in surgical and medical procedures and promoted it back up to the PT level. And then it looks like we left it alone for 3.5 years until in version 9, what we did was demote it again to an LLT level, but under a new PT called sinus operation. And the one thing you'll notice is despite what we did with it, its 8-digit code never changed. So that's important to note. Now, the last part of what it does is, remember I said to you that I had my data set? Well, what I can do is I can use the MVAT tool to tell me how the changes over this 3.5 years have impacted my data set, which is really all I care about. So what I'm going to do is I'm going to create my data set properly formatted, and these are instructions that are in MVAT to tell you how, the MVAT tool will tell you how to do it. And I'm going to take my data and I'm going to put it into MVAT tool and I'm going to run it. And it's going to take a few minutes and it's going to tell me how my 200 rows of data were impacted by changes that occurred over that period of time. And it may be that there are very few, if any, but it's telling me that I entered 201 rows of data. It analyzed 201 rows of data. And looking at it here, I can see that it hasn't had a tremendous impact on me. Of my 201 rows of data, one of the LLTs is now under a different PT. And I can select that, and it's going to show me exactly how my data set was affected. Now, this is just a small view of it because it was only 200 rows, but it can be just as effective if my data set was 10,000 rows. And really what it comes down to is, how are changes in MedDRA going to affect you in terms of recoding? Because again, it's about allocation of resources. So that was what I wanted to show you about the MVAT tool. And then before I go to questions and answers, I just want to take you to the MedDRA website and show you where you find a few things. So always look at the website, look in this banner over here, which is where we update new things that are about to happen. But under how to use, you're going to see something that says support documentation. If I click on that, it's going to take me to the support documentation page. And if I go under this blue banner, this is where I'm going to find the points to consider documents. Here's the term selection one. Here's one on data retrieval. Here's a companion document. On the other hand, if I go under this tab for version 27.1, it's going to show me some other things that are resources, like a document called What's New with MedDRA, What's New About the Release. This is an intro guide here that has about 90 pages of things about the organization of MedDRA and the rationale behind why it's organized the way it is. And here's the intro guide for the SMQs we talked about. This document is about 300 pages long. You don't want to read this document, but I would say this. If you were thinking about using the arthritis SMQ, you want to go in this document and go to the arthritis SMQ to see, first of all, how it's defined, what kinds of terms are included in this SMQ, what kind of terms are excluded in this SMQ. It'll tell you everything you need to know about the various kinds of SMQs. So that is one thing that we can see when we look at the website. There are other things that you can find as well, which is going to the downloads to download the desktop browser as well as MedDRA files. You go on here, as you probably did, to be able to schedule upcoming courses. You can also go on here and find training materials. So if I select training materials, let's say I go under coding, I can find all these various things. I can find streaming versions in multiple languages of various webinars related to coding. Let's Code, the advanced coding, the basic coding, all those things are in here. Coding medication errors. I can select things like data retrieval topics and find those things in here as well. These are all things you can find on that MedDRA website. So it is worth your while to go in there and root around and see what you can find. This also includes, for instance, our video cast. Everything from how do you submit a change request? How do you download the browser? How do you use the self-service application? It's all here. So I think that that's all we're going to cover today. What did we do? We talked about the background of information about MedDRA, its scope, its structure, its characteristics, how it's maintained. I showed you demonstrations of a couple of tools, the browser and MVAT specifically. Gave you a flavor for how coding is done, top down or bottom up with the browser itself. Showed you a couple of the documents related to points to consider, the one for term selection and data retrieval and presentation. We also looked at the website where you can find things like the SMQ guide and the intro to MedDRA guide. And we talked about SMQs as a specialized form of query. This is summarizing important sites. This is the MedDRA website. This is the email for the help desk. This is a link to frequently asked questions on the MedDRA website. The best part of it is not only do we have the questions, we have the answers as well. Links to the various browsers. How do you submit a change request, the training schedule, the support documentation. And so at this point, I'm going to stop and ask Sarah, what questions do we have from the audience?
Yes, we have just a few. The first one, it said, under what situation would I need to compare versions?
So it may be that you are in charge of data management, and you as the data manager are responsible for ordering enough resources to recode. For instance, suppose you work in big pharma, and every 6 months when a new version of MedDRA comes out, you need to up version to decide whether you need to change anything that may have been coded in the past. You might want to use the MVAT tool to get an idea in looking at the supplemental view of the web-based browser, how many kinds of cases you're going to need to potentially recode, because that will determine whether you decide, well, we'll set aside 2 weeks for it or a month for it, or we're going to need these number of people, especially if it's something that you have to outsource and there's a cost associated with it. So that's one way of using it. That's the way that most people in pharma use it, because you don't get the luxury in most cases of choosing one version of MedDRA and using it throughout the entire 6-7 years of product development. On the other hand, if you're writing research papers, you may want to decide which version of MedDRA do I want to use or base my research paper on. And you might want to get an idea of what do I benefit if I go to a more recent version versus the one that I used in writing the paper. Is it going to, change the conclusions of my report? Is it even worth doing? So those are a couple of circumstances under which you might want to do that. Now, the other point of what I would like you to also be aware of as well is, and let me do this because this will be helpful for you. Again, if I go to the website, here is a document called best practices. If I click that best practices document, it's going to actually take you to best practices in clinical trials, in which we provide you with a series of options related to upversioning. We start with option 1, and it goes all the way up to option 6. The way I would phrase this is, people say to me all the time, well, what should I be doing in terms of upversioning? The answer is, it depends upon what you're required to do and what you're capable of doing. So option 1 is kind of like riding a skateboard. This is where you choose a version of MedDRA. Let's say right now I started writing this research paper, and I did all my coding with version 27.1. And it takes me 6 years to finish my paper. And I decide I'm not recoding anything. I started with 27.1, and I'm going to write my paper and publish it with 27.1. Well, that's a luxury that I get because I'm a researcher, and nobody's going to skewer me because I didn't use the most recent version of MedDRA if my conclusions are still valid. On the other hand, when I get to version 6, this is recoding all the trial data for all trials in a project on an ongoing basis each time there's a new version of MedDRA. If you're big pharma with 250,000 employees across the globe, regulators may expect you to do that. And you don't get to say, well, we don't have enough resources. They're going to laugh in your face. So if you're the data manager, you want to be thinking about what resources do I need to accomplish that, because that's a requirement. And that's why you might want to compare versions of MedDRA. So what's the right answer? The right answer is, what do you need to do in the environment in which you work? And then you need to make sure you have the resources to do it. Next question.
Perfect. The next one, it says, I'm a bit confused about the concept of SMQs. I got that a single SMQ gathers all the relevant PTs related to that specific disease or condition, but how do I use it? So, for example, to retrieve safety data on my drug, which I am in the process of developing.
So the only way that SMQs will help you is if you are interested in one of the 110 topics that are covered by SMQs. So let's say you are developing the third drug in a class and the other 2 drugs are associated with agranulocytosis. You might want to use that SMQ to look at your data to see if you have cases of agranulocytosis that you may not have appreciated because you haven't seen the totality of the aggregate data, because you have, for instance, multiple medical officers within your organization. We chose those ones because, as I said, they are clinically important topics that can be deal breakers for certain drugs. If you have one case of progressive multifocal leukoencephalopathy, or PML, that's going to kill your drug in most cases, unless it's for an exceptional, it has an exceptional response in a very, very serious condition. I showed you SMQs just in the sense that they're available to you as a tool. The reality of this is most times, the things that you want to build a query for don't exist as SMQs, and you need to build the query of interest yourself. And that is a course that we teach called, it's the data building webinar, where we will teach you, if you wanted to, the principles of creating your own query if it's a topic that's not covered by one of the 110 SMQs. It's also discussed in detail in the PTC document on data retrieval and presentation. I hope that answers your question.
Perfect. The next one, it says, I want to ask that I didn't understand the multi-axial terms. May you explain it again, and what is the importance?
So if I were to ask you what organ system is affected in people who have COVID-19, you would say it depends. They could have renal disease, they could have dermatologic problems, they could have heart problems, they could have lung problems. So it is possible that concepts related to COVID would be in multiple SOCs within MedDRA. A PT could be in respiratory, and it could be in cardiac, and it could be in renal, and it could be in several SOCs. Now, how we decide which one of those SOCs for multi-axial PTs is the primary sock is not the scope of this particular webinar, but just to give you the idea of what the right answer is. If a PT is only in one sock, by definition, that's a no-brainer. It's going to be that sock because that's the only sock in which that PT occurs. On the other hand, if a PT is in multiple socks, the IMOs, when assigning the primary sock, make the best attempt to select the prime site of manifestation. So suppose we had a disease called doodle disease, and you look and it says doodle disease can affect the heart, the lungs, or the kidneys. That's pretty difficult because it's not telling you which is the predominant presentation. On the other hand, if it said doodle disease can affect the heart, the lungs, and the kidney, and 90% of people will have cardiac involvement, then in putting that one in, the concept would probably have cardiac as its primary sock, and lung and kidney would be secondary socks. So when it comes time for data analysis, this is when it's important, because you don't want to count up the cases of doodle disease. Let's say you had 3 cases. When you're looking in your cardiac sock, you'll get 3 cases there. But when you get to lung and kidneys, you don't want to count those same 3 cases a third time, a second and a third time, because then you'll suddenly conclude I have 9 cases when in fact you only had 3. So this is why multi-axiality exists, is that very often it is not possible to attribute a particular concept to just one sock. What gets a lot of people unhappy as well is when the primary sock is something that they think is wrong. But we do these things with a lot of caution and with a lot of thought. If I ask you what was the primary sock for chest pain, if I'm talking to an audience of cardiologists, they're going to say, well, I'm pretty sure it's cardiac disorders. But they'd be wrong. Because if I were to sit in the emergency room at a hospital on a Saturday night and look at the next 10 cases of chest pain that came in, probably 3 of them are going to be cardiac. But the other ones would be people who came in and said, I've been having pain in my chest since I fell off the ladder and broke 3 ribs. Or I've been having pain in my chest since I ate that bad salami. And what they're really describing is acid reflux, for instance. Or I've been having pain in my chest since that pulmonary embolus developed because it broke from the blood clot in my leg. So the point here is that we get into trouble sometimes because when you're a cardiologist, as the old expression goes, when you're a hammer, everything looks like a nail. They think that everything is cardiac in nature, when that's not the reality. So we have to be very careful what we do in terms of attributing primary sock. Someone asked me about general disorders and administration types conditions, and I want you just to look at this. This includes things like administration site reactions, body temperature changes, fatal outcomes. If I were to look here, MedDRA has all these mechanisms of death for coding purposes, general system problems, these kinds of things, therapeutic and non-therapeutic effects. These are all general disorders and sometimes relate to the site of administration as well. So again, to be really good at MedDRA, you have to kind of look in these socks and familiarize yourself with what concepts are in what socks, especially if you're trying to do a top-down sock search, because if you start in the wrong sock, you're never going to find what you're looking for. Other questions?
Yes. What does NEC stand for in the example, rate and rhythm disorders, NEC?
Not elsewhere classified. So let me explain what that's all about. We have a bunch of baskets that we create, HLTs, HLGTs. Now, in general, we don't want to have 250,000 HLGTs on a particular sock. So we may select 12 of them because that describes the most common baskets in which you should put cardiac disorders. But there may be other conditions that there's only 1 or 2 relevant concepts. And rather than creating an HLGT or an HLT just for those 1 or 2 concepts, we will have these higher level grouping terms that we will call the NEC ones, meaning they're kind of orphans and they didn't deserve the privilege of being a unique HLT or HLGT because there just weren't enough of that. Now we can put a bunch of these kinds of terms in these NEC groups. And in the future, if this concept expands and now there are 20 or 30 synonyms for it, it may be then that we create an HLT or an HLGT. The other one that I showed was not otherwise specified. And that goes back to how did MedDRA originate? When MedDRA originated, it was not created from scratch, but rather several existing terminologies were combined to begin to create the first version of MedDRA. And some of those old terminologies would have terms like not otherwise specified, where, for instance, someone said he had an unspecified cardiac problem, and they would have a term in one of these old terminologies for cardiac disease not otherwise specified. So we created MedDRA, and we have some of these NOS terms. And then after several versions of MedDRA, we said, well, that's embarrassing to continue to do that. We don't add NOS terms anymore. We make a point of having enough specificity in the description of the term that it's no longer necessary to have those NOS terms. Now, we don't eliminate the ones that we put in there previously because, again, as I said, when you go to retrospective data analysis and you want to go all the way back, let's say, to version 2.1, you need to have available to you all the LLTs that existed even that far back, even if they're NOS terms that we don't use anymore.
Great. And then right now for the last one, it says, do we use the MVAT tool to search for the code number of headache?
Do we use it to search? Well, okay, excellent question you've asked me. So here's the MedDRA terminology. Let's say I wanted to find headache. As you say, let's go down to nervous system, and here's headache. And I open that up, and now I'm going to start seeing all these different kinds of headaches. Now, your question is, okay, but you told us about all these codes. Where are the codes? Well, this is just my preference of how I have my browser open up. Because you'll see right here under display options, it says show codes. If I click that, look at what's going to happen. It's going to reopen MedDRA, and it's going to show all of those 8-digit codes. So if I go back now to headaches again and start opening these things, it's not only going to show me the terms, but it's going to show me unique 8-digit codes that are associated with every one of those terms. And again, there are very few absolutes in the world, but when we assign an 8-digit code to a term in MedDRA, it will never, 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 never change. So 20 years from now, the MedDRA code for tension headache is going to be 100432669. It's just a universal truth. And in 20 years, I hope to be around to be able to take a look and prove that's true. Any other questions?
That was it.
So, folks, I want to thank you. We ran, looks like 8 minutes over with questions, but again, I stay on to answer all the questions that are asked. This was an attempt to be an introduction. If you are anxious to learn more about MedDRA, we have so many different ways. You can sign up for face-to-face courses. I'm doing a face-to-face course in the United States in early October. If you go on the MedDRA website, you'll see that we are offering these courses internationally. So all you need to do is go and see if it's close by. We also have our webinars. Once we do our webinars, they're recorded. They're put on our YouTube channel. We have our video cast. We're constantly trying to do things. And we have something coming in the future where we're going to be having a learning management system where you can go into MedDRA and do your own training at your own pace with a self-paced learning management system that Sarah is involved in working with as well. The beauty of this is at 2 o'clock in the morning, if you have insomnia and you want to learn about medication errors, we have an LMS course on that, you're going to be able to go in and do that. And it will be structured in a way like most learning management that the things you're getting wrong, it will probably have built into it alternative algorithms to allow you to try again and again until you get a principle down before you move on to something new. So we're always constantly trying to adapt to what people need. Because again, one of the consequences of the pandemic is people are very hesitant sometimes or not allowed to fly long distances for training. So the more that we put at your disposal, either in real time or in your own pace, like an LMS system, the better you're going to be. There is so much out there to consume on the MedDRA website. It's worthwhile to take a look at. I want to thank everybody for their time and attention. I want to thank Sarah for her help today. And unless another question snuck in under the wire, I'm going to sign off for today. Anything left that came in, Sarah?
Nope, that was it.
All right, everybody, thank you for your time and attention. I hope that you found it valuable. Thank you for your continued support of MedDRA. Let us know how we can help you. Let us know how we can improve our product. And Dr. Dave Richardson signing off from today's webinar. Enjoy the remainder of your day.